Good afternoon. My name is Mary Beth Kinane, and I'm coming to you from Massachusetts. I actually don't work for ProScan, but it's a nice thought. And I'm going to be talking to you today about radiology of the globe and optic nerve. So we're going to start out talking about the globe. In that section, we're going to talk about abnormalities of size and shape. We're going to talk a little bit about ocular trauma, and then we're going to finish up talking about leukocoria and intraocular tumors. And then we're going to turn to the optic nerve. And in that section, I am going to show you a lot of different examples of optic nerve pathology. But what I'm really trying to do in that section is to give you a framework for understanding what you're going to see when you look at an exam. So let's dive right in with the globe. And let's start by talking about abnormalities of size and shape. As with everything else, globes can be too big or too little. We'll start out with too big. And the most common cause of large eyes is high myopia. I should mention that when you're looking at these cases, for the most part, you're looking at them for another reason. Large eye is not an indication for orbital MRI or orbital CT, but you will see these as incidental findings on exams that you look at. And when you look at eyes that are very large, it's puzzling to know exactly what to do with them. But the vast majority of the time, there's no really severe pathology going on. These are mostly people who are just extremely nearsighted. Every once in a while, these patients will come to imaging because their eyes are so big and long that they actually protrude from their orbit. This is called pseudoproptosis. This is a recent patient who came to us who had eyes that were bulging out of his orbit. He was felt to have maybe thyroid eye disease, so he came to us to look for evidence of thyroid eye disease. Now you can see the muscles are normal, and there is no increase in intraorbital fat. This is just a huge eye. Remember that for most people, the reason that you're nearsighted is because the focal point of the lens is in front of the retina. The retina is too far back. People who are very nearsighted have very long eyes. The retina is very far behind the focal point. As that globe stretches out, it develops areas of weakness in the sclera, and those areas of weakness are called staphylomas. So here you can see, instead of having a normal curvature posteriorly, there's a little focal bulge called a staphyloma. So when you see these very elongated eyes with bulges posteriorly, this is most commonly myopia. Rarely you can get ophthalmos. This really occurs in infants who have elevated intraocular pressure. And it's so commonly associated with elevated intraocular pressure in a very juvenile eye that in ophthalmology it's used almost interchangeably with congenital glaucoma. These kids have eyes that are uniformly large. They don't just elongate, they uniformly get bigger. In addition, their cornea is larger and their anterior chamber is larger, as you can see when you compare this eye to the contralateral eye. How can you tell the difference? Well, generally speaking, again, a ophthalmos eye is still very round. The whole thing is bigger. It's bigger in all directions, whereas the myopic eye is very elongated. The anterior chamber is larger, whereas in myopia, the anterior chamber is normal in size, the cornea is normal in size, and frequently you will see associated staphylomas with myopia. Let's turn from that to small eyes. Anophthalmia and microphthalmia frequently exist along a spectrum. And the goals of imaging when we look at these kids are to identify any ocular tissue that should be preserved to preserve vision, to identify any associated abnormalities in the orbit, and to identify any associated craniofacial abnormalities. So here's a range of patients with anophthalmia, microphthalmia, starting in the upper left. This was a child who presented to the ophthalmologist with no visible ocular tissue on physical exam. When you look at the imaging, there's no ocular tissue in the right, but there is a very tiny globe on the left. When globes are small, they can be very well formed. Small globes, sort of like a miniature globe, that's called nanophthalmos, as you can see here. Or there can be associated abnormalities. And two of the most common are PHPV, which we'll talk about a little bit later in the talk, and coloboma. Colobomatous microphthalmos is associated with 70% of cases of microphthalmos. And remember that a coloboma is a defect along the embryonic fissure. When the optic vesicle forms, it invaginates on itself to form the optic cup, and then the optic cup fuses inferiorly. And that line of fusion along the inferior aspect of the globe is called the embryonic fissure. When you have a coloboma, you have a gap in that closure. And if that gap involves the sclera, then the uvea can prolapse out, forming a colobomatous cyst. In addition, if you have this hole in the sclera, then you can't maintain normal intraocular pressure in utero. And that normal intraocular pressure is important for achieving the normal size of the globe. So if you can't maintain a normal intraocular pressure, you can't have a normal size globe. Frequently, the terms coloboma and staphyloma are confused. So to review, a coloboma represents a defect in the sclera, whereas a staphyloma is just a weakening of the sclera, a focal bulge. A coloboma is a congenital abnormality. Staphylomas are acquired abnormalities. Colobomas always are located along the inferior aspect of the globe because that's where the embryonic fissure lives. Whereas a staphyloma can be anywhere, but tends to be more posterior because it's associated with axial myopia, and that's where the sclera gets weakness as it's being pushed posteriorly. Coloboma is often associated with small eyes because you cannot maintain normal intraocular pressure. Staphyloma is often associated with large eyes because myopia is one of the most common causes. Again, a big eye with a focal bulge, staphyloma, a small eye with a colobomatous cyst, coloboma. Now, up to this point, we've talked about congenital causes of small eyes. You can also acquire small eyes if you develop what's called a tisical eye, or ptysis bulbi. Ptysis bulbi is the end stage of multiple different diseases. People can have ptysis bulbi because they had bad ocular trauma. People can have ptysis bulbi because they had bad ocular infection. It represents the end stage. These are non-seeing eyes. They tend to shrink over time, and they frequently calcify as well. So when you see a small calcified globe in a normal-sized orbit, that is a globe with ptysis bulbi. We're next going to turn to ocular trauma. Patients with ocular trauma, at least at our institution, will almost always come to CT. And the most important thing that the clinician is looking for is the presence or absence of a foreign body because it determines the timing of surgery. If a patient has a foreign body, they go to the OR within the next 6 hours. Whereas if they don't have a foreign body, they can wait a little bit longer. It's a next day surgery rather than a same day surgery. We also want to look at the contour of the globe for evidence of rupture, look at the anterior chamber for changes in dimension of the anterior chamber, and finally look at the lens. Here is a patient with a BB in the anterior chamber. Of all the pictures I'm going to show you of trauma, this is the one where we really have to make the finding. It's not a subtle finding, but this is the most important finding that you're going to make in a setting of ocular trauma. We can also look at the contour of the globe to see if the contour and the shape is maintained. This is a very obvious ruptured globe. This is a much less obvious case of ruptured globe. This is a patient who had a posterior rupture due to blunt trauma. In an anteriorly ruptured globe, the clinician can frequently see the full thickness corneal perforation or the full thickness scleral defect. In a posterior rupture, that rupture is not visible to the ophthalmologist. We can sometimes recognize it because we can see widening of the anterior chamber. The lens, remember, is supported on zonules, but the zonules have a little bit of motion to them. And so as the pressure is lost posteriorly, the lens will drop back a little bit, widening the anterior chamber. Of course, decrease in the size of the anterior chamber can also be a sign of ruptured globe as aqueous leaks out a full thickness corneal perforation. When we look at the lens, we want to make sure that it is well centered in the anterior chamber. If there are rips in the zonules due to trauma, the lens can become partially dislocated. If the zonule is completely ripped, the lens can be fully dislocated. This is a patient who had Marfan syndrome and relatively minor trauma. In addition, you can occasionally see a traumatic cataract. Now, a cataract is a clouding of the lens, but in trauma, the clouding of the lens is due to the lens capsule being ruptured and fluid entering the lens. When that fluid enters the lens, to us, the lens looks decreased in density because fluid is lower in density than the protein of the lens. So this is a traumatic cataract. Okay, and finally, before we move on from the globe, we're going to talk about leukocoria. Leukocoria is loss of the normal red reflex, and the most important cause of leukocoria is retinoblastoma. It is also the most common ocular tumor that causes leukocoria. There are other causes, including PHPV and Coats disease, which I'll show you examples of as well. This is an example of leukocoria. When you take a photograph or when you shine a light into a baby's eye, you should see a normal red reflex. This is the normal reflection of light on the retina. On the other side, you see a white reflex as light bounces off the tumor and then back to you. Retinoblastoma is the most common pediatric intraocular tumor. Remember that 40% of these patients have a mutation in all of their cells. They have a mutation of the retinoblastoma gene in all of their cells, and those patients develop multiple bilateral tumors. 60% of the patients will have sporadic tumors. These are unilateral. In the past, we often used to do CT for these patients. CT is really falling out of favor in the evaluation of retinoblastoma. CT is falling out of favor in a lot of indications for kids because of the exposure to radiation, but this group of patients has such a large population of kids who have an abnormality of a tumor suppressor gene. They are felt to be more susceptible to the effects of radiation. So the evaluation consists of an exam under anesthesia, ocular ultrasound, and then MRI for select cases, especially if they involve the optic nerve head. When we look on MRI at retinoblastoma, the features that you expect to see are calcification, particularly in large tumors. Pretty much all tumors over the size of a centimeter have some degree of calcification. These tumors are densely cellular, so they tend to be somewhat bright on T1 weighted images and dark on T2 weighted images, and they demonstrate avid enhancement. So here is a retinoblastoma in the right eye. You can see that there is mildly hyperintense compared to the normal vitreous. On T2 weighted images, it's very dark. On susceptibility weighted images, you can appreciate some calcification. This is a different patient who has a retinoblastoma on the left, and you can see the avid enhancement associated with it. Now, all of these children get exams under anesthesia, but just as a matter of thoroughness, it is good when you're doing these exams to look at the contralateral eye or the same eye for additional tumors, as 40% of patients will have multiple tumors. Here is a large retinoblastoma in this eye, and then on the contralateral eye, a very tiny additional retinoblastoma. When we do MRI in retinoblastoma imaging, the thing that MRI achieves that ultrasound and exam under anesthesia do not achieve is improved evaluation of the optic nerve posterior to the optic nerve head. And also we can see any associated intracranial abnormalities. When retinoblastoma involves the optic nerve sheath complex, it can either extend into the nerve itself. So here is abnormal enhancement extending beyond the lamina cribrosa, which is the point at which the optic nerve meets the posterior globe. And in this case, there's also extension of tumor along the dural covering of the optic nerve. Either of those findings increases the risk of relapse. They're very important findings to report, and these children receive adjuvant chemoradiation. In addition, obviously, MRI is going to be better than an exam under anesthesia for detecting any intracranial abnormalities. This is referred to as trilateral retinoblastoma. These intracranial tumors happen in the kids who have bilateral disease or multiple retinoblastomas. They are intracranial PNETs. There is a 5 to 15% incidence in these kids, and although they are frequently thought of as occurring in the pineal region, which is why they're termed trilateral, because the pineal is thought of as the third eye of the brain, they just as frequently occur in the suprasellar region. These unfortunately carry a very grim prognosis because they can rapidly seed into the rest of the central nervous system. So patients with retinoblastoma typically present with leukocoria, but not all patients with leukocoria have retinoblastoma, and the most common mimic is persistent hyperplastic primary vitreous. In utero, the vitreous of the eye conducts blood supply from the posterior aspect of the globe to the lens. When that vitreous persists, that vasculature can persist in a canal known as Cloquet's canal. When you look at these patients, they typically have microphthalmia. That persistence of the primary vitreous does not allow full development of the eye, so the eyes are small. They tend to have hemorrhagic retinal detachment. These vessels bleed frequently. They have an abnormal lens with retrolental soft tissue, and frequently you'll see a linear structure extending from the retina to the lens, the residuum of Cloquet's canal. Coats disease is a much rarer form of leukocoria. It is primary retinal telangiectasia, and these patients develop lipoproteinaceous effusions, which tend to be bright on T1 weighted imaging. How do you tell the difference between retinoblastoma and some of these mimics? One of the most helpful features of retinoblastoma is calcification. A large abnormality in the eye, if you're thinking it's a retinoblastoma tumor, should have some calcification with it. In addition, when there are retinal detachments in retinoblastoma, you can usually see an associated mass with those retinal detachments, unlike PHPV, where you just see a retinal detachment but no associated mass. Before we leave the subject of the globe altogether, remember that in adults, we don't get retinoblastomas, we'll see choroidal melanomas. The most common intraocular tumor of the adult is the choroidal melanoma. These patients typically do not come to imaging. They're diagnosed on physical exam and ultrasound. When they do come to imaging, you can frequently see a tumor that is T2 hyperintense, avidly enhancing, and may be intrinsically T1 hyperintense on the pre-contrast images due to the presence of melanin. All right, we're going to move on to the optic nerve. Optic neuropathy describes dysfunction of the optic nerve, and there are many signs of optic neuropathy that can't help you distinguish between optic neuropathy and other causes of visual loss. So, for example, loss of visual field, loss of color vision, loss of acuity. When a clinician, however, tells you that there's an afferent pupillary defect, that is a physical exam finding which is very specific for the optic nerve. If they've told you there's an afferent pupillary defect, they are telling you that there is dysfunction of the optic nerve specifically. Most patients will also have abnormalities of the optic nerve head on exam, though some, for example, patients who have retrobulbar optic neuritis do not have abnormalities of the optic nerve head. It's difficult to image the optic nerves. You have to have a dedicated study to do it. If you have a patient with optic neuropathy and they ask you to look at a brain MRI to tell what the cause is, that's usually not going to do the trick. The optic nerve is very small. And unfortunately, many of the causes of optic neuropathy cause nonspecific findings. So we're going to look at some of the causes at the top of this list: compressive or infiltrative causes of optic neuropathy, inflammatory or infectious, and then we'll talk briefly about some of these causes, particularly ischemic. What ends up happening if you're doing an exam for optic neuropathy is that as the radiologist, at the end of the exam, you're going to end up in one of three places. Either you know exactly what's causing that patient's optic neuropathy, and that's pretty much the compressive causes of optic neuropathy. Or you can help with the answer if you look at the other findings in the brain, if you look at the electronic medical record, if you look at the serologies the patients had drawn. Those are usually the inflammatory or infectious optic neuropathies. And then you're going to have a bunch of cases where you have no idea what's going on. It's very nonspecific findings. So let's start where we can be the most helpful, and that's with compressive or infiltrative optic neuropathy. These are patients who have mass effect on the nerve or infiltration on the nerve. And most typically they have mass effect on the nerve. And that mass effect will either be from a tumor or from a tumor pushing on from the nerve sheath, or from a structure completely outside of the optic nerve sheath complex, from the sinuses, the vessels, or the bone. The most classic example of this is the optic nerve meningioma, in which you can see a tumor that arises outside of the nerve along the dural sheath. You can see the nerve in the center here, but the nerve itself is not involved by tumor. It's compressed by this tumor on the outside. These typically have what's called tram track enhancement. Meningiomas can occur solely along the optic nerve, or they can be spheno-optic meningiomas that involve both the sphenoid bone and the optic nerve. Now, anybody can see this meningioma, but we really earn our keep when we find this meningioma, which, although tiny, can produce very significant visual symptoms because it's at the optic canal, where there's really no room for a pushing mass. So this also is a very tiny optic nerve meningioma which can present with very dramatic visual symptoms. These pheno-optic meningiomas can be unilateral or, as in this case, bilateral. Here you can see enhancing soft tissue surrounding both optic nerves in the optic canal. But meningiomas are not the only things that can cause compressive optic neuropathy. This was a patient who had a headache for a month and then gradually developed visual symptoms, and you can see a very large aneurysm here. Here's the left prechiasmatic optic nerve with T2 signal abnormality as it's being pushed by this aneurysm. This is a patient who had paranasal sinus disease with mucoceles in the sphenoid sinuses. Here you can see erosion of the floor of the optic canal bilaterally as this disease pushed on the optic nerves. When the sinus disease was relieved through surgery, when that pressure was relieved, the patient's optic neuropathy improved. When you see infiltration and enhancement and enlargement of the nerve itself, you're most commonly looking at an optic nerve glioma. These are benign tumors of the optic nerve, grade 1 pilocytic astrocytomas. Much, much, much more rarely you can see metastases of the optic nerve. So when we're talking about compressive optic neuropathy, MRI is often specific for the diagnosis, and when you finish looking at one of these cases, you ought to be able to at least say there is or there is not evidence of a compressive optic neuropathy. Frequently, that is the most important thing to convey to the clinician. So let's look at the infectious and inflammatory causes of optic neuropathy. Of these, probably the most common is demyelinative optic neuritis presenting as a manifestation of multiple sclerosis. But you can also have sarcoidosis, idiopathic orbital inflammatory syndrome, and occasionally you'll see patients who have neuroretinitis. These patients usually don't come to imaging because usually their retinitis is detected on physical exam and they don't require anything more for the diagnosis. Occasionally the optic nerve dysfunction will present in advance of the retinal changes. Those patients frequently come to imaging. These are cases where if you look at them, you will see T2 signal abnormality and enhancement of the nerve itself. And remember, when you're looking to see whether an optic nerve is normal or not, instead of looking at the contralateral optic nerve, which may be involved as well, it's helpful to look up at the subcortical white matter of the frontal lobe. So you can see this is too bright and enhancing. When you look at the brain, you can see demyelinative plaques. This is a case of demyelinative optic neuritis. Here's another case where you have bilateral T2 signal abnormality and enhancement of the nerve itself. There's nothing about the imaging that tells you what this is, but if you look at the electronic medical record, you may see that the patient's ACE level is elevated. This was a patient with sarcoidosis. This is a patient who has some signal abnormality and enhancement right at the optic nerve head, just extending a little bit posteriorly into the optic nerve. You can also see some thickening and enhancement of the scleral uveal coat. This is toxoplasmosis with an optic neuritis and an associated chorioretinitis. Finally, this is the patient who did not present for optic nerve imaging. She presented in follow-up for nasopharyngeal carcinoma. You can tell that she has some radiation change in her temporal lobes with patchy enhancement and T2 hyperintensity. And there's also this enhancing optic nerve. Again, this doesn't look necessarily, when you just look at the nerve, it doesn't look any different than the demyelinative causes. It's the associated findings that tell you what it is. So for the inflammatory optic neuropathies, the diagnosis can be suggested taking into account the clinical findings and additional findings in the brain. These are all cases where you see T2 signal abnormality and enhancement of the nerve itself. So suppose you look at the exam and all you see is T2 signal abnormality of the nerve. Now, what could it be? Well, unfortunately, there's a whole laundry list of diseases this could be. But we'll talk about ischemia. And the reason we're going to talk about that is because many of the other causes will not come to imaging. How commonly are you going to run into nonspecific findings? Well, glaucoma is the most common chronic optic neuropathy in the United States. And NAION, which I'll expand upon in just a minute, is the most common acute optic neuropathy in patients over 50 years old. Now, the glaucoma patients typically don't come to imaging. They are known to have glaucoma. But these patients present with acute visual loss, and especially if they're younger and they don't have a couple of the other findings that clinicians associate with ischemia, these patients may come to MRI. So you should at least know what it is that it probably is if you don't see anything. When the clinicians talk about ischemic optic neuropathies, they describe them as either being anterior or posterior. Anterior really means just the optic nerve head. The whole rest of the nerve behind the head is posterior. And arteritic or non-arteritic. In other words, do you have temporal arteritis or giant cell arteritis, or is your visual loss not related to that? The non-arteritic anterior ischemic optic neuropathy describes ischemia in the distribution of the posterior ciliary arteries, which just supply the optic nerve head. They do not supply the remainder of the optic nerve. And so the cases that we're going to see are these cases right here. Remember, the sort of alphabet soup of it is divided into anterior and posterior, arteritic and non-arteritic, and the cases that we're going to see are the non-arteritic anterior ischemic optic neuropathy. Now you might say to yourself, well, if it's an ischemic disorder of the optic nerve, then why wouldn't you just look at the diffusion-weighted imaging? But diffusion is very hard, first of all, very hard technically to do in optic nerves because they're a small structure and we're just looking at the optic nerve head, which is even smaller. There's a lot of susceptibility artifact, and there really isn't a large body of research that can tell you what to do with an abnormality when you see it on diffusion. So some of the cases are pretty straightforward. This is a patient who had mucormycosis. You can see the abnormal enhancement in the nerve sheath, representing the infection of vascular invasive fungus into the nerve sheath. It's not a shock to see diffusion abnormality in this case because you know that the blood supply to the nerve has been choked off by these fungus. But even in this patient happened to be imaged 2 days apart. And when they were imaged on a 1.5 Tesla magnet, it was easy to appreciate the diffusion abnormality. When they were imaged on a 3 Tesla magnet, because of the increased susceptibility, you can't even appreciate this diffusion abnormality. So it can be unreliable. In addition, there are other things that cause diffusion abnormality in the optic nerve and the optic nerve head. Within the past year in AJNR, papilledema has been described as a cause of diffusion-related abnormality just in the optic nerve head. And this is a patient who had papilledema in the case of idiopathic intracranial hypertension, not ischemic optic neuropathy. So unfortunately, at this point, we can't really diagnose ischemic optic neuropathy. So hopefully at the end of this talk, I've informed you about some of the things you're going to see in the globe, particularly in cases of leukocoria. We've talked a little bit about an approach to the optic nerve, and I hope you enjoy reading these cases when you're back at your home institution. Thank you.
Good afternoon. It's a privilege to be with you. Thank you to Dr. Curtin for inviting me to be in this session and for putting me with such outstanding speakers. By being in the middle of both of them, I can only help by basking in their reflected glow, so thank you. We're going to talk about orbital tumors, which includes neoplastic disease and non-neoplastic masses that are found in the orbit. By way of disclosure, I have a relationship with the medical publishing company Amersis. I would also like to acknowledge the many colleagues who have helped contribute their case material to this presentation. Learning objectives, I'm sure you've already read these and memorized them, so we'll just go on. When approaching the topic of orbital tumors, it is useful to pick a couple of points of consideration along which we can organize our thought process for deciding what the lesions are. We might look at the anatomic and/or organ of origin of the lesion. There are pathologic categories that provide a useful construct for thinking about. In some cases, the demographics, and particularly the age of the patient, can be useful in the differential considerations. And then, of course, what are the specific CT and MR imaging features? If we organize our discussion along these ideas, we come up with a number of groups of lesions to talk about. These include lesions of the optic nerve and/or sheath, glioma and meningioma, lesions that center themselves in the lacrimal gland, including primary epithelial tumors and lymphoma, lesions that are diffuse or multifocal, a number of pediatric and adult lesions, of course, metastatic and other related conditions. The inflammatory group of diseases, which we will defer mostly to the next talk, but we'll just hit on those very briefly. A couple of lesions that are structural or bony in nature, in particular developmental cysts, and a related lesion which is not specifically a tumor, but it has a mass-like effect related to the maxillary sinus. And then finishing up with lesions of vascular origin, including malformations and neoplasms. So first, lesions of the optic nerve and sheath. We've seen already some very nice examples of this. Briefly, we will once again review optic pathway glioma. The more common of these two is a low-grade astrocytoma, like a pilocytic. It does have a minor NF1 association, meaning most patients with NF1 don't have this, and patients with this by and large don't have NF1, but there is a definite association. These occur in younger patients, have a relatively mild visual defect given the impressive size that these lesions often have. On imaging, we're looking for a mass arising within the optic nerve and or any other part of the pathway. These lesions are hyperintense on T2. They can be variable, as in this very large mass occupying much of the intraorbital segment of the optic nerve. They can have a variable amount of enhancement, and as with other pilocytic type tumors, the enhancement is more striking than you might expect given the benign nature of the lesion. This is an example of bilateral optic pathway tumors involving both optic nerves, the chiasm, and even extending into the proximal pathways. Optic nerve sheath meningioma, by comparison, is seen in an older patient population, more often females. It is also a benign lesion. It presents with progressive painless vision loss in this demographic. On imaging, the characteristic appearance is that of a tram track lesion, meaning it is on both sides of the optic nerve but not involving the optic nerve. In this case, we can see the characteristic calcification along both edges of the optic nerve. That is a very useful and probably the most important differentiating feature in this lesion. In a similar fashion, the enhancing portion of the tumor along the sides of the optic nerve in the sheath also shows a tram track pattern of enhancement. And a related finding is what is called a perioptic cyst. The presence of the mass effect, often in the posterior aspect of the orbit, results in an accumulation of CSF right behind the optic nerve head that is called a perioptic cyst and is somewhat specific for meningioma. An example of a patient with bilateral disease, in this case a donut-like enhancement around the optic nerve, as we would expect to see involving the dura. On the other side, there is an eccentric crescentic mass also arising from the dura, but in this case just on one side. This case is to remind us that lesions of the optic nerve and sheath sometimes are difficult to distinguish. This is a teenage patient with vision loss. This should have been an optic pathway glioma, but ended up being an optic nerve meningioma, showing that when these lesions get large, they can be sometimes difficult to tell apart. Lacrimal gland tumors include a short set of etiologies. They include lymphoproliferative disease, which is about a third or more of lesions that start here. Pleomorphic adenoma, again about a third or more of these. And then carcinoma of the lacrimal gland, the bad actor here, which is about a quarter or so. We'll talk about lymphoproliferative disease in just a moment when we get to multifocal diffuse diseases. One important clinical point here is that symptoms can differentiate between benign and malignant lesions, in particular with regard to one of the epithelial carcinomas in the lacrimal gland. Benign mixed tumor is the most common benign tumor of the lacrimal gland, also known as pleomorphic adenoma. This shows up as a solid discrete mass, as we see here, well-defined, occupying the lacrimal gland. It is usually the case that you cannot tell the difference between normal glandular tissue and the mass in these. Characteristically, they show benign bony scalloping, as in this coronal scan. You can see that the large benign mixed tumor has caused a thinning and a scalloping of the bone without evidence of erosion that is typical of this slowly growing benign lesion. One point to make is that these can rarely turn into and degenerate into a carcinoma, aka carcinoma ex pleomorphic, as in this patient with a very aggressive tumor that is involving the extracondylar orbit, has invaded the regional bone, extracranial space, as well as severe intracranial extension in ex pleomorphic adenoma. By comparison, adenoid cystic carcinoma is a primary epithelial malignancy that can occur in the lacrimal gland. It is an aggressive and an unfortunately insidious lesion, as this graphic depicts its characteristic tendency to invade into regional structures. One very important point is that these patients present with pain and paresthesias, which is different than patients with BMT and is an ominous sign when it is found clinically. These are infiltrative masses that get into the adjacent structures. On imaging, bony destruction is a feature that is an important thing to recognize. In this case, an adenoid cystic carcinoma in the lacrimal gland that is invaded through the roof of the orbit into the frontal sinus, and you can even see a little bit of intracranial tumor. This is a very ominous sign in this very difficult tumor to treat. One thing to remember is that when these lesions are small, they may appear benign, and so a lesion of the lacrimal gland needs to be addressed. Let's move on to diffuse and multifocal tumors of the orbit. Lymphoma is going to be the most common of this category that we will talk about. Lymphoma is actually a spectrum of lymphoproliferative conditions that ranges from a benign polyclonal reactive process all the way to a full-fledged lymphoma, which is often of the MALT, the mucosa-associated lymphatic tissue variety. These lesions tend to be radiosensitive and therefore are treatable and have a good prognosis. On imaging, these lesions show up as solid enhancing masses, as we see in this case, retrobulbar and along the lacrimal gland. One common pattern of manifestation is originating within the lacrimal gland and then extending posteriorly into the lateral aspect of the orbit, as seen in this case. These can involve any part of the orbit and have a tendency to have what is called a plastic or infiltrative tendency, in that they sort of get into and around all the structures of the orbit, as in this case with extensive lymphomatous infiltration throughout much of the retrobulbar orbit. One thing to remember is that these lesions have a tendency to mimic other inflammatory and or granulomatous diseases. In this case, mass involving the lateral rectus, lacrimal, and even intracranial disease. This is lymphoma, but it could just easily be a granulomatous process such as sarcoid or even extensive idiopathic disease. Metastatic lesions of the orbits, we see them more commonly in adults. Clinically, they often present with rapidly onset of ophthalmological symptoms. They can involve the muscles, as we see in this case in a patient with breast cancer, the fat, and of course the bone with secondary orbital extension. A couple of types of lesions worth remembering. Breast cancer, as seen in this patient with metastatic disease with this irregular enhancing mass behind the globe, can cause what is referred to as a serous metastasis, in that it tends to cause a contraction and it can even result in an enophthalmos, which is paradoxical to what you might think with a mass in the orbit. Melanoma also is known for its predilection for involving the orbit. It is less common than perhaps things like breast and lung, but we often see it present in the orbit, as in this patient with multiple lesions in the orbit, as well as in the regional soft tissues. And then because the optic nerve sheath is a dural structure with CSF continuity, when you have intracranial disease, you can get carcinomatosis, as in this patient with breast cancer, showing CSF dissemination into the CSF space surrounding the nerve. Briefly, we'll touch on pediatric malignancy. There can be much more to be said about this, but a couple of points worth making. Common lesions worth remembering include primary malignancy, and in particular, rhabdomyosarcoma. This is a patient with a large, bulky mass, T2 hyperintense, with irregular thick enhancement and areas of necrosis in the orbit, rapidly growing with proptosis. Whenever you see a lesion of this type, almost regardless of its imaging features, you need to consider rhabdomyosarcoma, because it can take on a number of imaging manifestations. Hematologic disease can sometimes occur around the orbit, as in this case with a unifocal manifestation of Langerhans cell histiocytosis. There can be, of course, more extensive disease, as in this patient with orbital and extensive skull base multisystem Langerhans cell disease. Leukemia and other hematologic conditions can also present with infiltrative solid sheets of enhancing cells. And then metastatic disease in the pediatric population is more limited than the adult population, but sometimes has particular manifestations, such as this patient with neuroblastoma metastatic to the orbit and skull base with its characteristic hair-on end appearance. As long as we're talking about pediatric orbital masses, it's worth looking at the constellation of findings that is associated with NF1. There are specific orbital manifestations that are characteristic. First of all, optic pathway gliomas. In this case, we can see these multiple very large areas of enlargement of the optic pathway going all the way into the intracranial compartment. Plexiform neurofibromas, which are these multiple nodular and serpentine masses that the more you look, the more you find them in these patients. Sphenoid defects, which is a broad opening in the greater wing right along the pathway, the course of the superior optic fissure. These lesions can be quite dramatic, as in this 3D, which shows this broad opening at the back of the orbit. Interestingly, these are not congenital lesions. These lesions tend to grow over time and are thought to be associated with the presence of plexiform neurofibromas. And then enlargement of the eye, ophthalmos. This is probably not the best use of this term, more appropriately, as we just heard from Dr. Kanan, but an enlargement of the eye as an isolated phenomenon can be seen in neurofibromatosis. When you see this constellation of features, it is basically pathognomonic for NF1. We'll just touch briefly on inflammation, deferring this discussion mostly for the next talk. But some of these lesions can present as masses. They include idiopathic orbital inflammation, as in this case showing lateral rectus and lacrimal involvement, sarcoidosis in this patient with optic nerve, muscle, and even intracranial disease, and Wegener's disease with its characteristic nasal, septum, bony, and orbital invasive tendencies. But again, we will wait for this to be discussed in more detail later. A couple of structural lesions of the orbit to talk about. Dermoid and epidermoid cysts are epithelial inclusions. These are ectodermal inclusions that are congenital in nature. When it is a dermoid, it involves all layers, meaning it has dermal appendages such as sebaceous glands and follicles. When it is an epidermoid, it includes the outer layer only, less complex and less complex contents. These are seen typically in children, although occasionally they won't show up until later in life. They can rupture, resulting in a severe inflammatory cellulitic appearance. They tend to occur along suture lines, in particular supralateral in the region of the frontozygomatic suture. Second most common is be in the supranasal location. On imaging, we're looking for lesions that appear cystic, round, well-defined, as in this case. They will often have debris or fluid levels in them reflecting the contents within. These tend to have scalloped margins because they are benign and slowly growing. About a half of them will have lipid material internally due to the sebaceous or fatty contents. In this case, you can see that the density is similar to that of your intrinsic control of subcutaneous fat, indicating that this is a fat density material. And a minority of these will also show some focal calcification. This is an example of a dermoid cyst, this case laterally to the orbital wall, but again, that very characteristic scalloping. It has internal, low-density fat material with layering debris inside the cyst. This is an example of an epidermoid on MRI. We can see that on T1, it's mostly low signal, perhaps a little bit of heterogeneity and debris inside, very bright on T2. Again, notice if you look up close that this has characteristic scalloped, benign-looking margins that are characteristic of a long-standing process. Maxillary atelectasis is not a tumor, but because it causes a mass-like effect, I thought I would include it in the discussion here. This is also called silent sinus syndrome. It is a phenomenon of acquired chronic sinus obstruction that leads to a collapse of the maxillary sinus walls. The reason why this affects the orbit is because it results in a depression of the orbital floor, changing the volume of the orbit and resulting in the symptoms of diplopia and enophthalmos. And if you look at this on the sagittal plane, you can see why this is taking place. This downward bowing of the orbital floor, although it looks like a mass effect, it's actually an atelectatic vacuum effect from the sinus causing that floor to be depressed. We'll finish up with the category of vascular masses. In discussing these, it's important to take a couple of pathologic considerations into account. These lesions may be neoplastic or they may be developmental. Hemodynamics are important, especially from the surgical point of view. The natural history can help us understand what kind of lesion we're dealing with. And then terminology is important here, especially with regard to the terms malformation and hemangioma. In comparing these two categories, malformations and neoplasia or tumors proper, there are a few kinds of malformations to consider. Venolymphatic malformations are lesions that are congenital. These are endothelial-lined channels that have subtypes based on flow that we'll talk about. There is the orbital cavernous lesion, which is a different kind of lesion. It is very common and unique to the orbit, and we'll talk about that. And then there is the true AVM, which is a congenital lesion relatively rarely found in the orbit. If we compare malformations to tumors, on the other hand, we have the infantile hemangioma, which is a very common lesion seen in young infants. The congenital hemangioma, which is less common and a more recently described phenomenon. And hemangiopericytoma, which is an adult vascular mass. Let's talk first about vascular malformations. One way to classify these that the surgeons like to think about has to do with their flow. So the flow-based classification includes the following types. Type 1, they have no flow, meaning they don't have a systemic venous connection, and the endothelial-lined channels are not in continuity with the remainder of the vascular system. Type 2 are those lesions that have venous flow. It may or may not have a distensible component, and we'll show an example of that. And then type 3, which is arterial flow, which includes, interestingly, the cavernous lesion, and then, of course, true AVMs. The first two types, 1 and 2, collectively can be thought of as what we refer to as venolymphatic malformations. So let's talk about those. The venolymphatic malformations are congenital, dysplastic, unencapsulated collections of these endothelial-lined chambers. They have variable venous and or lymphatic components, tend to show up in children or young adults. Clinically, they show up with progressive proptosis, often with these episodes of sudden increase due to the propensity of this lesion to hemorrhage acutely. They tend to recur frequently and are surgically challenging and therefore difficult lesions for management. On imaging, these lesions are multispatial, infiltrative, cystic, and multilocular. Here we see on T2 fat-sided image a characteristic appearance of these multiple loculated lesions with complex internal contents. One of the most important characteristic features is that of fluid levels, reflecting blood products often of different ages within. So here we can see within each of these compartments a fluid level of a slightly different location, indicating the multilocular and hemorrhagic nature of this lesion. There can be a variable amount of enhancement depending on how much venous component there is. Here's that same lesion we just saw. Again, we can see these discrete fluid levels within the multilocular components, a small amount of enhancement that is reflecting the venous component of the lesion. These lesions can get very large, and elsewhere in the head and neck, we see these multispatial lesions that can be very deforming and very challenging. This is just a more extensive variation of the intraorbital type of lesion. Terminology then. The terms cystic hygroma, lymphangioma, and hemangioma have all been applied to this. But these are old terms, and we should probably avoid using them and stick with the proper pathologically correct term, which is venolymphatic malformation. Orbital varix is an interesting variation of a venolymphatic malformation. It has a venous component that is low flow, but interestingly has this distensible piece to it. Here's an example of an orbital varix at the apex of the right orbit, showing intense enhancement from the vascular nature. These lesions also tend to hemorrhage with associated clinical presentations. Interestingly, they have this phenomenon of intermittent proptosis that is reproducible. The patient can sense and can be induced and reversed through a Valsalva. This is an example of a patient with an orbital varix on quiet breathing. Imaging of the orbit with contrast shows essentially no abnormality. But after about 10 seconds of Valsalva, we see this lesion pop up seemingly out of nowhere that represents that distensible venous component filled with contrast. Orbital cavernous malformation is a very interesting, very important lesion. It is common in the orbit, often referred to as the most common benign orbital mass in adults. This is a vascular malformation, not a hemangioma. Interestingly, it has somewhat arterial flow features, often referred to as a low-flow AVM, and presents with painless, slow growth, tends not to hemorrhage. On imaging, we're looking for a well-defined ovoid mass lesion, as we see in this left orbit. The vast majority of these are intraconal. Calcification, interestingly, is uncommon in this orbital lesion. They have a pseudocapsule due to their very slow outward growth, compressing the surrounding tissues, resulting in what is often seen as a chemical shift artifact on MRI. And as you would expect, they show avid enhancement, as in this case on the left orbit. These can be demonstrated to have a dynamic fill-in pattern if you do dynamic imaging. And here's an example of a lesion over the course of about 1 minute showing a dynamic fill-in pattern of this orbital cavernous malformation that is reminiscent of malformations that we might see elsewhere in the body. With regard to the name, the term orbital cavernous hemangioma is often used. It is ubiquitous. The surgical community prefers to use it, and so we need to be aware of it. But it's important to remember that this lesion is not hemangioma. It is a malformation. It is unique to the orbit, and it does not behave like other venal lymphatic malformations, so we need to keep it apart. I recommend using the term orbital cavernous malformation. That term cavernous will cue the surgeon that we're talking about the same lesion. Finally, vascular neoplasms. These include infantile hemangiomas, also referred to as capillary hemangiomas. These are very common lesions and have typical phases that we'll talk about. Congenital hemangiomas, which is a distinct lesion, relatively recently discovered or described. It has 2 subtypes. And then in the adult population, hemangiopericytoma, which is a vascular neoplasm of the orbit. Infantile hemangiomas are very common lesions. They present shortly after birth, technically not congenital. These are very common, more often seen in the female population. They have their characteristic phases, which include the proliferative phase, usually during the first year of life, the involuting phase, and finally the involuted phase, which can take up to a few years to resolve, often spontaneously, although in some unusual circumstances can be persistent and more difficult to treat. But spontaneous resolution would be the norm. An important pathologic feature is that these have an antigenic marker, the GLUT1 marker, that is positive on pathologic stains. On imaging, these are lobular infiltrative lesions, often in and around the preseptal orbit. They can be infiltrative. They tend to be very intense enhancement, as you would expect, and in the superficial periorbita. They may have more extensive regional facial and intraorbital extension, as in this case with postseptal, periorbital, and as well as a deep face involvement. In these cases, can be more difficult to treat when they become this extensive. These lesions have high flow characteristics that can be documented on ultrasound, and in fact, in a very young patient, crib-side evaluation with ultrasound can be a useful way to confirm a suspected diagnosis if it's in question. By contrast, congenital hemangiomas are, as the name suggests, congenital. They are present at birth. They are much less common than the infantile hemangioma. What's interesting and somewhat difficult is that they have a very similar appearance to infantile hemangioma. Again, we see an intensely enhancing mass in and around the periorbita. What's important to remember is that these have a pathologic distinction in that they are GLUT1 antigen negative, so they are pathologically a different lesion. There are 2 subtypes that are classified on their natural history: the rapidly involuting variety, the rich, or the non-involuting congenital hemangioma, the niche variety. And finally, hemangiopericytoma, another vascular neoplasm that can occur elsewhere in the head and neck, but has a manifestation that is somewhat characteristic in the orbit. It shows up as a painless mass, more often in middle-aged adult patients. On imaging, we're looking for a well-defined mass with enhancement, somewhat of a predilection for the superior orbit or the lacrimal fossa, although it can occur anywhere. And based on these descriptors, you might imagine that this would be a very good mimic for orbital cavernous malformation, which it is. It does show intense enhancement, but because of the imaging and clinical features, it is a much less common but important differential for the orbital cavernous malformation. In summary, then, we were able to look at orbital tumors from a number of different standpoints. We talked about lesions of the optic nerve and sheath, lesions originating from the lacrimal gland, diffuse and multifocal tumors in pediatric and adult populations, including metastatic and hematologic disease, inflammatory masses touched on briefly, and we're looking forward to hearing about more from that next. A couple of lesions that involve the structural bony aspects of the orbit, and rounding out with vascular malformations and neoplasms. Thank you very much.
Good afternoon. I also want to start by thanking Dr. Curtin for the invitation to speak to you all today. We're going to go over infection and orbital inflammation for the next 30 minutes. And orbital inflammation specifically can be very complicated because of the many overlapping clinical and imaging features. So they overlap with each other and they overlap with neoplasm, as we've just heard from Dr. Davidson. So I went to our oculoplastics team and our orbital pathologists for help to understand how we as neuroradiologists can have the greatest impact in the treatment of these patients and the diagnosis of these patients. So I'm going to share those clinical pearls with you all throughout this talk. Our learning objectives are first to recognize the imaging features, the imaging patterns of orbital inflammatory diseases. Second, to understand the clinical scenarios, and not just the clinical presentation and demographics, but how are these patients managed so that we can offer a limited differential diagnosis and help to guide biopsy and understand the complications of orbital infection. So we're going to start with orbital infection, then we're going to move on to the more complicated topic of orbital inflammation. We're going to spend most of our time talking about the common causes, thyroid eye disease being the most common, and nonspecific orbital inflammation, also known as idiopathic orbital inflammation or orbital pseudotumor. Then we're going to talk about the less common causes of orbital inflammation where we need a biopsy to make the diagnosis. Contrast-enhanced CT is the most common modality used for acute infection, and MRI for orbital inflammation. We often use orbital MRI when we're looking for extension for invasive fungal sinusitis, so we're going to see MR cases in that scenario also. The different imaging patterns in the orbit that we're going to focus on in this lecture are enlargement of the extraocular muscles, which you can see most commonly with thyroid eye disease and nonspecific orbital inflammation, but a group of other diagnoses that we also need to consider, as we've already seen examples of. Enlargement of the lacrimal gland also can be seen with nonspecific orbital inflammation, but we need to also consider sarcoid lymphoma. We saw some cases of epithelial tumors and even infection. And then the ill-defined mass has a very similar long list of differential considerations. So as you can see, any single diagnosis can have multiple image patterns, and any single pattern on imaging could be multiple different diagnoses. So just on imaging alone, these patterns often overlap. And that's why clinical history is so key, to know the patient age, the presence or absence of pain, signs and symptoms of infection, so fever, leukocytosis, and what is the onset? Is it rapid or gradual? So if a patient comes in rapid onset with the presence of pain and fever, we're thinking of infection. Rapid onset and pain without fever or leukocytosis, the major consideration is nonspecific orbital inflammation. Patients with a gradual onset and that are painless, these are often caused by the more specific causes of orbital inflammation, sarcoidosis, thyroid eye disease, or neoplastic considerations such as lymphoma. Patients will often come to us with a clinical history of proptosis. So on imaging, our evaluation of proptosis, you can draw the interzygomatic line between the anterior aspect of the zygoma bilaterally, and approximately a third of the globe should be behind this line. This is a case of thyroid eye disease, and you can see that the entire globe is anterior to the interzygomatic line. So we're going to start off talking about orbital infection. These patients often present to the ophthalmologist with fever, leukocytosis. They're trying to get the history of a recent upper respiratory tract infection or sinusitis. And clinically, they will often have conjunctival chemosis and pain. So that clinical scenario can overlap with nonspecific orbital inflammation that we're going to talk about a little bit later. So to the clinician, when a patient presents like this, those are the major two diagnostic considerations that they're thinking of. And as the infection progresses from preseptal location to a postseptal location, it's more likely that the patient will present with proptosis and or decreased vision. And this is a nice scheme that Dr. Cunane published in the Salmon Curtin chapter that looks at the different types of orbital infections, starting with preseptal cellulitis, which can often be from abrasion or lid lacerations. Here, there's no proptosis. The vision here is not at risk. But as the infection progresses, and there's postseptal cellulitis, which is often from sinusitis, with the ethmoid sinuses being the most common culprit, as you progress from postseptal cellulitis to subperiosteal abscess to orbital abscess, there's increasing chance that the patient is going to present with vision loss. So here's our first patient. You can see has preseptal soft tissue swelling and a dacrocystocele that's infected. And this is preseptal cellulitis with dacrocystitis. And what's important to remember here is that when you have an acute dacrocystitis, it's often associated with a preseptal rather than postseptal cellulitis because the orbital septum inserts at the posterior lacrimal crest. The orbital septum is a fibrous tissue that is contiguous with the orbital periosteum, and superiorly, it comes from the superior orbital rim down to the levator aponeurosis, which then attaches to the superior tarsal plate. Inferiorly extends from the inferior orbital rim to the inferior tarsal plate. And just superficial is the orbicularis oculi muscle and then the skin. So here's a recent case that we had. A 50-year-old who came in with fever and left eye swelling. This came in overnight and was called preseptal cellulitis, and the patient was sent home on oral antibiotics. And what you can see is a hyper-enhancing lacrimal gland, but there's a collection here deep to the lacrimal gland. So one of the important questions to ask yourself here is this preseptal versus postseptal, because that will affect how this patient is managed. And this is actually a case of dacryoadenitis and postseptal cellulitis. Dacryoadenitis, as we'll see, most often is a non-infectious inflammation of the lacrimal gland, but occasionally it can be infectious, and these patients need IV antibiotics. And it's important that we make this distinction of pre versus postseptal cellulitis because the postseptal space has a different venous drainage, which can go back to the cavernous sinus, and so these patients are at risk of cavernous sinus thrombosis and vision loss in the postseptal space. So they're monitored much more carefully. They're kept as inpatients with daily monitoring of the vision. So the learning point in this case is that the lacrimal gland itself is postseptal. So all of this infection is postseptal. And our oculoplastics doctor sent me these images to illustrate that. So when you make the skin incision, you see the orbicularis muscle. And then as you cut through the orbicularis muscle, you can see the orbital septum. And then when you cut through the orbital septum, here you see the septum and here you see the orbicularis muscle, then you see the orbital fat. That central fat pad. And you actually have to move that central fat pad, elevate it, to be able to see the deeper lacrimal gland. So here's a patient, a 5-year-old, so a child with rapid proptosis, fever, and pain. So all the clinical signs and symptoms of infection. So one of the things that we want to look at is, do we see signs and symptoms or signs on our imaging of sinusitis? And we do see that there's ethmoid sinus disease. We're looking for orbital extension, and here's a very characteristic appearance and location of a subperiosteal abscess. These can have visual disturbance in up to 30%. They're most common in children, and they can be treated with IV antibiotics alone for children. They need to be drained if there's no improvement or if there are visual changes. This next case is a 28-year-old. She had no other medical history other than the fact that she was 7 months pregnant. And unfortunately, when she first presented on the 15th here, she already had pre- and postseptal cellulitis. And whenever there's postseptal cellulitis, because the venous drainage is back to the cavernous sinus, you always need to check the cavernous sinus. And this patient already had soft tissue abnormality in the cavernous sinus and narrowing of that carotid. And unfortunately, despite aggressive medical treatment, she developed a pseudoaneurysm of her cavernous carotid. So always check the cavernous sinus in cases with postseptal cellulitis. So cavernous sinus thrombosis, this is the dreaded complication. Patients are very ill with meningitis and cranial nerve palsies. Our patient actually had her ICA coiled in that case. So we're going to switch gears now and talk about patients that are immunocompromised. So here's a 47-year-old with leukemia and neutropenic fever. So with that history, we all know that what we're looking for invasive fungal sinusitis. And it's important to know where to look. I always start with a nasal cavity because 2/3 of these cases start in the nasal cavity and start in the middle turbinates. And here's a very characteristic imaging feature on the postgadolinium. We see this area of non-enhancement in the middle turbinate, the so-called black turbinate sign. The next thing is to look outside the nasal cavity and the sinuses. And in here, the coronal images are really key to look at that subtle infiltration of the inferior orbit that we see in this case. If you're going quickly through the axials, it would be easy to miss that. And this was aspergillus in this patient with leukemia. Acute invasive fungal sinusitis mucormycosis is more common in diabetics, aspergillus in the neutropenic patients. They're both rapidly progressive, mucor more so than aspergillus. These need very early intervention because once they've spread outside the sinuses to the orbit or intracranial compartment, the mortality is exceedingly high. So I always start, even on the non-contrast CT sinuses, looking in the nasal cavity. On MRI, for orbital spread, I use the T1 weighted images to look for infiltration of the fat, and here's a case in the preantral and retroantral fat, and you can see that it has spread superiorly into the orbit. So we look here along the orbital floor and along the medial orbit for spread in invasive fungal sinusitis. And here's a case that I had right out of fellowship, and this is a patient with ethmoid sinusitis and retrobulbar soft tissue in a diabetic patient. My knee-jerk response was invasive fungal sinusitis, but here's a case where knowing that clinical scenario would have helped me. This was a patient with controlled diabetes, gradual and painless onset, and this is a mimicker of T-cell lymphoma. This is a very subtle case, and the clinical history on several non-contrast CTs was headache. The actual history was retroorbital headache, and this reminds me always to check the orbital apex as part of my checklist in patients with headache. And here you see subtle dehiscence along the posterior lamina propria and soft tissue here in the orbital apex, and you can see that to better advantage on the T1 weighted image. And then, of course, we're going to look back at our cavernous sinus. We see it spreading right back to the superior orbital fissure to the cavernous sinus. And there's asymmetric enhancement along the wall of the internal carotid artery here. And this is vascular invasion from mucormycosis. And this patient succumbed to aneurysm rupture several days later. The treatment for invasive fungal sinusitis really centers around reversing the predisposing condition. Our surgeons are still aggressive with surgical debridement, but much less so than they were in the past, because if we don't reverse the predisposing condition, then these patients cannot be cured. So now we're going to switch gears and talk about orbital inflammation. This is a very heterogeneous group of disorders. When there is no discernible cause, that's when we're calling it idiopathic or nonspecific, which is a better name than pseudotumor because it reminds us that we don't have a diagnosis, because inflammation per se is not a diagnosis but a response to an underlying cause. And when patients don't behave the way that we expect, we need to always consider rebiopsy. Our orbital pathologist divides these into specific causes, those that we can make by lab tests and pathology, and non-specific causes, and that's the idiopathic or non-specific orbital inflammation. And in the back of our minds when we're reading these cases, we always need to be considering lymphoma, because as we've seen from Dr. Davidson's talk, lymphoma is the great mimic and another common cause. So some clinical pearls. Patients with nonspecific orbital inflammation will come in and usually have acute, painful, unilateral presentation. So when a patient comes into the ophthalmologist with that presentation, the major considerations to them are nonspecific orbital inflammation or infection. So how can we help them the most? Well, look around for signs of infection. So on imaging, look for sinusitis, look for an abscess, and of course looking for signs of bone erosion, which is not common with nonspecific orbital inflammation. In patients with the specific inflammatory conditions, and that's the thyroid eye disease, sarcoid, Wegener's, these patients normally have a subacute presentation, painless, and bilateral. And thyroid eye disease is the most common cause in this category. Management pearls. So if a patient improves with steroids, it's not necessarily diagnostic of nonspecific orbital inflammation or pseudotumor, because the neoplastic causes can temporarily improve with steroids, and even the causes of specific orbital inflammation can improve with steroids. So biopsy is needed in many of these cases. But there are 3 scenarios that we can avoid biopsy if they present with that very typical acute, unilateral, painful onset. And that's the myocytic form, orbital apex soft tissue form of nonspecific orbital inflammation, and then inflammation or dacryoadenitis of the lacrimal gland. So we're going to look at those 3 patterns now. The first pattern is extraocular muscle enlargement. And when I see a case of extraocular muscle enlargement, the guiding principles that I'm thinking of are that thyroid eye disease is the most common, and it's typically bilateral, as we've seen. It spares the tendinous insertions, and then I remember the mnemonic, I am slow, for the involvement of the extraocular muscles, the inferior, medial, superior, and lateral rectus before the obliques. Nonspecific orbital inflammation involves those tendinous insertions and tends to have more shaggy borders. And in the back of my head, I'm thinking of excluding a CC fistula. So here's a 75-year-old who came in with proptosis and vision loss and very typical imaging features of thyroid eye disease. You can see the extraocular muscle enlargement, and you can see the smooth borders with the orbital fat. It's sparing the myotendinous junction, and this is very characteristic for thyroid eye disease, which is an autoimmune orbital inflammation. The majority of patients are hyperthyroid, but they can also be hypothyroid or euthyroid. Most common in females, and they typically present with eyelid lag and retraction. And clinically, one of the most important things they're going to be evaluating for is optic neuropathy. So how's the vision? And so on imaging, we always want to look back at the orbital apex for compression of the optic nerve. If there is compression of the optic nerve, they can either do a surgical decompression or treat with radiation. This patient was on Coumadin and so was treated with radiation. On MRI, you want to look at the T2 signal characteristics. If they're hyperintense on T2, it's a more acute presentation, and those patients are more likely to respond to steroids acutely. This next case is a 37-year-old, had hypothyroidism after radioactive iodine, and presented with proptosis and diplopia. So we already have the clinical history that this person has thyroid disease, and although the abnormality here is unilateral, we can see involving the inferior rectus, the medial and the lateral rectus, because of the clinical presentation, this is unilateral thyroid eye disease, so less common, only 10% of the time. Steroids were not effective in this case, and this patient was treated with radiation. The The next case is a 46-year-old with left eye pain. So a different history. This patient came in with a painful left eye and proptosis. So the pain is making us think of nonspecific orbital inflammation. The onset wasn't as acute as we would like. The patient had been having pain for 3 months. But the imaging appearance here is much more suggestive of nonspecific orbital inflammation. You can see the involvement of the lateral rectus. The myotendinous junction here is involved. It is not spared. And on the coronal, we see that lateral rectus, and to a lesser degree, the superior complex is involved. This patient was biopsied because of that protracted presentation at 3 months, and the biopsy showed nonspecific inflammation. Isolated lateral rectus involvement, if you do see that, that is suggestive of nonspecific orbital inflammation. So this is the myocytic form, and of the myocytic form, 95% are unilateral. So if you see it bilaterally involving the extraocular muscles, be thinking of thyroid eye disease. Another thing about the imaging that we're going to talk about a little bit later is looking for this dark T2 signal in patients with nonspecific orbital inflammation. Suggests that they're more likely chronic or fibrotic. And this particular patient responded well to steroids and did not need radiation or any other drug therapy. Nonspecific orbital inflammation, as we've discussed, is a diagnosis of exclusion. The etiology is not clear as to whether this is infectious or autoimmune. The top two clinical presentations are pain and periorbital swelling, most commonly unilateral. Some chronic or fibrotic forms do not have pain, so this is the atypical presentations that you have to be thinking about. And we're going to also look at a case of the Delosa-Hunt variant that has cavernous sinus involvement. Nonspecific orbital inflammation can have a number of different patterns. We just looked at the myocytic pattern. Can also present with lacrimal enlargement, lacrimal gland enlargement, diffuse or apical forms, and then Dr. Cunane talked about the anterior and perineuritic forms, so we're not going to discuss those in this talk. This last case of the extraocular pattern of abnormality, you see enlargement of the extraocular muscles, but when you look closer at this case, you can see the superior ophthalmic vein is enlarged and the cavernous sinus is bowed with multiple small flow voids within the cavernous sinus, and this is a CC fistula. And you can see early filling of the cavernous sinus on an ICA injection. So this is something just to keep in mind with that extraocular pattern. The next pattern is enlargement of the lacrimal gland or a lacrimal mass. And the guiding principle here is if the patient presents with painless lacrimal enlargement, they're going to get a biopsy. No matter what we say, if it's painless, they're going to get a biopsy. So how we can help, we can look around for perineural tumor. We can look around for bone erosion, as you saw in Dr. Davidson's talk. So we can help in that way, but if it's painless, they're going to go to biopsy. Here's a patient with 38-year-old female, intermittently painful eye swelling, and she had a history of lupus. So they've already treated her for the possibility of infection. They've given her antibiotics, and she's not getting better. And there is a presence of pain, and we can see involvement of the lacrimal gland and lateral and superior orbit. And this was nonspecific orbital inflammation in a lupus patient. So typical histology for nonspecific orbital inflammation in the acute setting: polymorphic lymphocytes, plasma cells, eosinophils, chronic fibrosis, and scar. This patient did not do well with steroids and was ultimately treated with radiation. This leads to the question, is nonspecific orbital inflammation an autoimmune disease? Well, there is a high association with other autoimmune diseases, and many of these patients will respond to autoimmune medications. So many believe that there is an autoimmune component. This is a companion case to show you that lymphoma can exactly mimic nonspecific orbital pseudotumor in the lacrimal fossa. Both can have this putty-like appearance in the orbit where they don't indent the globe. Here's a 67-year-old with proptosis, and she has bilateral enlargement of the lacrimal glands. This was painless. She went on to a biopsy, but when you have this bilateral appearance, You think painless, sarcoid, lymphoma, Sjogren's. Those are kind of the top things in the differential here, and this turned out to be sarcoidosis, a systemic granulomatous disease. Sarcoid, as we've seen so far, can have a lot of different presentations in the orbit, but chronic dacryoadenitis is the most common. You can also see extraocular muscle infiltration, so that's why that's included in the differential of all of these different patterns. And our last pattern that we're going to discuss is the infiltrative mass, diffuse or apical. And the guiding principle here is that if it's the first episode and acutely painful, they can have a trial of steroids if the imaging features are typical. Here's a patient, acute bilateral pain and proptosis, abnormal soft tissue molding to the globe like this putty-like appearance bilaterally, and this was non-specific orbital inflammation. This patient responded to steroids and never had a recurrence. The next patient had a painful ophthalmoplegia, has abnormal soft tissue in the orbital apex. It's extending back through the superior orbital fissure, and you can see the normal superior orbital fissure here, the orange star, extending back to the cavernous sinus. The ICA on that side, the flow void is missing, so it's occluded the ICA. It's also involving foramen rotundum, so many of these infiltrative abnormalities can involve multiple different cranial nerves. And also pay attention to how dark the T2 signal here. This is very important to mention in your dictations because these patients are often more difficult to treat. To remind everyone how to find the superior orbital fissure on imaging, once you find the optic canal, it is inferolateral to the optic canal here and should contain fat. So you see the replacement of fat here on the abnormal side. And this was a Tolosa-Hunt variant. These are usually steroid responsive, and they don't have to go to biopsy. Our case is an unusual case. It was dark on T2 and a sclerosing variant. And this patient had extensive workup. Actually, they did, you can see the post-procedure changes where they tried the biopsy, found fibrosis, and this patient after radiation also did not improve, and they're about to start another rituximab as a monoclonal antibody to B cells. This next patient reminds us of why pseudotumor we have to always consider rebiopsying, and that's not the best name, and we should think of this as nonspecific orbital inflammation. This patient had a diagnosis of pseudotumor and came to us with lymphadenopathy. And you can see the soft tissue in the orbit and the submandibular node. So when we saw this, we said that we're worried about lymphoma, sarcoid, Wegener's, and even IgG4 related disease. We biopsied that node. And this was IgG4 related orbital inflammation. These patients often have systemic lymphadenopathy, involvement of the salivary glands, and even pancreatitis. This leads us to an advancement in the nonspecific orbital inflammation in the sclerosing subtype, which we used to think of as a sequela of chronic idiopathic orbital inflammation, but it might actually be a very specific subtype related to the IgG4 related disease that don't respond well to typical medications. And this is our last case. This is a 46-year-old male with facial pain and proptosis. And the imaging clues to the diagnosis here are the pan-sinus disease. We see both osteoneogenesis, and we also see bone destruction along the nasal septum and the palate, and extensive involvement into the orbit. And this is Wegener's granulomatosis, and the major clue is the sinus tract involvement here. This is an autoimmune necrotizing granulomatous vasculitis, common in the sinonasal tract, but the orbit is the first extrasinus extension site in the head and neck. The treatment here, also steroids and chemotherapy. So in summary, for infection, you want to ask yourself and your clinicians about clinical signs and symptoms of infection. It's very important for us to help them distinguish pre versus post-septal. For inflammation, those three typical patterns, knowing the most common causes and the clinical scenario will help you guide your clinicians. Thank you all so much for your attention this afternoon.
As people are leaving, this is part of a virtual meeting. There are probably thousands of people around the McCormick Center that are doing this. We only had one question, but if there are other questions, we still have a couple of minutes. Otherwise, the speakers will be around. The one question, probably the first one of this refresher course, Dr. Aiken, do you perform a pre-contrast CT series when looking for post-septal collection in a child? Go for it.
We do not. A small disclaimer is that I don't work in a pediatric hospital, but so we don't image children, but on call we do this quite frequently for orbital cellulitis, and we do not do a pre-contrast scan, mainly for radiation purposes.
So are there any other questions for any of the speakers? If not, or if you think of any, they'll be up here for a little bit. Thank you.